Welcome to the Industrial Athletic Trainers Society Continuing Education Program On-Demand series. We're excited to have you join us and dive into this tailored content created just for you. Whether you're looking to expand your knowledge, sharpen your skills, or stay current with the latest industry insights, you've come to the right place. Our On-Demand series allows you to learn at your own pace, anytime, anywhere. Stick around until the end for important instructions on how to claim your on-demand continuing education credit. Thanks for choosing the Industrial Athletic Trainers Society. Let's get started.
Welcome, everybody. Today we're going to talk about some considerations with the diabetic worker, and this will be presented by Chris Proctor. So Chris is a seasoned regional program manager and certified athletic trainer with over 16 years of experience across diverse settings, including occupational and industrial health, clinical environments, and secondary school and college athletic training. Currently, Chris manages a team of industrial injury prevention specialists across the central United States for Work Care, a physician-directed occupational health service company. Chris holds a master's in occupational health and safety with a focus on environmental management from Columbia Southern and a bachelor's of exercise science and health education from Radford University. Passionate about advancing the athletic training profession, Chris is dedicated to the education, mentorship, and implementation of innovative health and safety programs in the industrial setting. Thank you, Chris, for supporting our program.
Society and a regional program manager with Work Care. Neither of these roles are directly affected by this presentation, and there are no financial relationships to disclose. A brief rundown of my background. As Mike mentioned, I did my bachelor's in athletic training at Radford University in 2008. Eventually, I did my master's in occupational safety and health from Columbia Southern University in 2019. I've worked in the traditional setting in clinics, providing outreach, athletic training coverage to several high schools and one JUCO. But a majority of my career has been spent within the industrial and occupational health setting of athletic training. So within the industrial and occupational health setting, most of my time has been spent in manufacturing, but I've also worked in distribution centers and with public safety. During my time in Southern Illinois, I spent 5 years in the Southeastern Illinois Community Health Coalition, serving as president from 2016 to 2017. I was also part of the Diabetes Today resource team there. I co-chaired the Healthy Lifestyles Action Team, and I was a facilitator for both the Stanford Diabetes Self-Management Program and the Chronic Disease Self-Management Program. During today's course, we will define what diabetes mellitus is, identify potential complications of diabetes. We're going to consider workplace accommodations and discuss screening and early identification of diabetes. So, diabetes mellitus is defined as a group of metabolic disorders of carbohydrate metabolism in which glucose is both underutilized as an energy source and overproduced due to inappropriate gluconeogenesis and glycogenolysis, resulting in hyperglycemia. Today, there are over 38 million Americans with diabetes, or roughly 11.6% of the population. With close to 2 million new diabetes diagnoses per year, diabetes is the most common endocrine disease in the United States. And of the estimated 38 million Americans with diabetes, it's thought that over 8 million are currently undiagnosed and unaware they even have diabetes. Diabetes can be diagnosed by either plasma glucose levels or hemoglobin A1C. A fasting plasma glucose level greater than 126 milligram per deciliter, or a 2-hour oral glucose tolerance test of 200 milligrams per deciliter, or an A1C value of 6.5 or greater. Diabetes can also be broken down into several classifications and clinical categories. We'll be focusing on diabetes mellitus types 1 and 2, but be aware that there are other classifications out there, such as gestational diabetes mellitus and diabetes insipidus, among others, which each have their own classifying criteria, causes, and potential complications. So type 1 diabetes, it's estimated to be between 5 to 10% of diabetes cases. It was previously referred to as juvenile diabetes. It's a condition where the pancreas either doesn't make enough insulin or it doesn't make it at all. In type 1 diabetes, the body's immune system mistakenly attacks the insulin-producing cells in the pancreas, which leads to a chronic deficiency of insulin. Type 1 diabetics require constant monitoring of their glucose levels, and they must inject insulin via syringe, pen, or pump to manage their blood sugar levels. Type 2 diabetes, which accounts for 90 to 95% of diabetes cases, is a metabolic condition of insulin resistance. So in the case of type 2 diabetes, their bodies produce enough insulin, but their cells aren't able to use it properly. Pre-diabetes is also a metabolic condition with insulin resistance, but it just hasn't reached that threshold yet for type 2 diabetes. With lifestyle changes and sometimes medication, many people can prevent their pre-diabetes from ever reaching the diagnostic criteria of diabetes. The first obstacle we have to consider for diabetes is just the general stigma that goes along with the condition. I think even we as healthcare providers have just this natural inclination to believe that type 2 diabetics are to blame for their condition. I think it's important that we acknowledge the role of lifestyle choices in the development of the condition, but also acknowledging there's much more to it than that. We need to be sure to address health concerns without judging the person for their condition. In many cases, the employee will benefit from knowing that you see them as a person, not their disease. Diabetes it's a chronic disease with lifelong implications. Most of what the general public thinks about diabetes is that it's an inconvenience and diabetics have to watch their sugar intake. But as we'll discuss through this course, it's much more than that. The development, complications, and management of diabetes is complicated, especially as it pertains to worker health. And the athletic trainer is an essential piece of the healthcare team, keeping the diabetic worker healthy. So for the next few minutes, we're going to talk about some of the complications of diabetes. So cardiovascular disease, it's the #1 cause of death in people living with diabetes, resulting in 2/3 of the deaths in people with type 2 diabetes. People with diabetes are twice as likely to have heart disease or a stroke than people without diabetes. Although diabetic ketoacidosis happens most frequently in type 1 diabetics, it is possible for a type 2 to suffer from DKA. Diabetic ketoacidosis occurs when the cells don't get the glucose they need to function. So they start to burn fat for an energy source, which produces ketones as a byproduct, which can build up in the blood, causing the blood to become acidic. This can lead to diabetic coma or death if not treated quickly. Chronic hyperglycemia causes the kidneys to work harder to filter blood, and over time it damages the kidneys, leading to chronic kidney disease. Other chronic conditions like hypertension increase the stress on the kidneys and increase the risk of chronic kidney disease in diabetics. Diabetic retinopathy is the leading cause of blindness in American adults aged 18 to 64. The number of individuals with diabetic retinopathy is predicted to increase by 48% by 2030. Peripheral neuropathy can be caused by chronic hyperglycemia, which affects the hands, arms, feet, and legs, and it often starts in bilateral feet. This peripheral neuropathy can be characterized by tingling, numbness, neurogenic pain, or weakness, especially at night. The circulatory and nerve deficits can lead to tissue damage that may lead to amputations. This is particularly important with work designed for diabetics. Peripheral neuropathy can be a contributing factor to cumulative trauma disorders like carpal tunnel or cubital tunnel syndrome, and can amplify the symptoms experienced with thoracic outlet compression syndrome. When an employee complains of numbness, tingling, and pain in their extremities, it could be a typical presentation of a cumulative trauma disorder, but it just may be a complication of diabetes. Obviously, we don't want to jump the gun and attribute it to any single condition, but we want to collect all the data to help form the big picture. Decreased circulation and poor peripheral sensation increases the risk for skin integrity issues, including bacterial and fungal infections. Also, the increased inflammatory response to plaque in your teeth makes diabetics more prone to gingivitis, periodontal disease, halitosis, and potentially tooth loss. We don't yet know the exact reason for the higher level of hearing loss in diabetics, but it's hypothesized that the chronic hyperglycemia damages the blood vessels in the inner ear. Most of the current research into diabetes and its effects on general health and well-being are focused on microvascular conditions like retinopathy and neuropathy, or macrovascular conditions like heart disease and stroke. Advances in medical technology and medications for treating diabetes have helped diabetics live longer lives with better quality of life, excuse me. Not nearly as much research, though, has been placed on the prevalence or cause of musculoskeletal conditions in diabetics. It's hypothesized that some cause of musculoskeletal conditions in diabetics can be attributed to changes in collagen deposition and changes in the glycosylation and connective tissue, negatively affecting the protein lifespan and its interaction with other proteins. Diabetics are more likely to experience musculoskeletal conditions like frozen shoulder, carpal tunnel syndrome, trigger finger, Dupuytren's contracture. Diabetes is also associated with general joint stiffness and pain, joint swelling and deformities, muscle pain, and fatigue. It's important to realize the effect diabetes has on musculoskeletal conditions and be aware that diabetics may experience these at a higher rate than non-diabetics. So some signs and symptoms that should be considered in the big picture and might be an indication that the worker needs further evaluation. Polydipsia, excessive thirst. So the body triggers the thirst feeling to increase water consumption with the idea of flushing out the excess glucose through the kidneys and out in the urine. Polyuria, excessive urination. It goes hand in hand, obviously, with excessive thirst because you're drinking more water and there's more to get rid of. Polyphagia is extreme hunger. When your body can't get the fuel to the muscle cells, it sometimes thinks it needs more fuel and triggers that feeling of needing to eat more to be able to provide that fuel that your body needs. Unexplained weight loss. So this seems counterintuitive, but a sign of type 1 or type 2 diabetes when you're considering with other signs and symptoms can be unexplained weight loss. Obviously, this can also mean other conditions. So it's just one thing to take into consideration when looking at the big picture. Then unregulated or poorly managed diabetes can increase the occurrence of infections. So this might be something that you as the on-site healthcare provider would notice. If an employee seems to have more skin infections or lesions than what you would expect in the normal population, this may be one sign to consider in assessing their condition overall. If those infections or other injuries are taking longer to heal than what you would normally expect, this may be another sign to consider that diabetes might be a contributing factor to their condition. Of course, neither of these directly point to diabetes as the automatic culprit, but they should be taken into consideration when putting together that whole picture. So those symptoms on the previous slide are all mostly chronic in nature. Usually they arise gradually over time, and they're often ignored by the person experiencing the symptoms because of their gradual chronic nature. But let's talk about some signs and symptoms of an acute diabetic emergency. Some things that might indicate an employee is in a diabetic crisis or a diabetic ketoacidosis include dry skin and mouth, flushed face, dizziness, nausea, vomiting, diarrhea, blurred vision, headache, and a telltale sign of diabetic ketoacidosis is fruity breath. Because this can be life-threatening, whether from hyperglycemia or hypoglycemia, it's a good idea to test blood glucose on anyone exhibiting these acute symptoms and arrange for immediate further evaluation. Ideally, that would take place in an emergency department. It's also important to note that both hyper and hypoglycemia may present very similarly to intoxication in some people. Confusion, dizziness, slurred speech, decreased motor coordination, and even personality changes like irritability can all be attributed to intoxication, hypoglycemia, or hyperglycemia. In the case that someone is exhibiting these signs, it's important to determine the cause before jumping to any conclusions. Maybe they have a substance abuse problem. Maybe they're diabetic and haven't managed their glucose very well. They may not even know that they have diabetes. Several years ago, I was working with a JUCO in Illinois, and one day the softball coach wasn't at a game. The assistant coach relayed that he was acting irritably, which was not out of character for him, but he was also acting confused and disoriented and actually fell down. When they took him to the hospital, his blood glucose was over 600. He blacked out, didn't remember anything from that morning, including driving his granddaughters to school. So he was a type 2 diabetic and had no idea before that day. Have you ever experienced someone in a diabetic crisis, whether hyper or hypoglycemic? It's something to think about. So the first and most obvious factor to blood sugar levels is diet. Carbohydrates. The carbohydrate intake directly impacts blood glucose levels. A good protein and fat to carbohydrate ratio can slow the blood sugar increase and round out spikes in blood glucose. Diabetes medicines can lower blood glucose. Some other medicines, like steroids, can elevate blood sugar, often for several days. Neglecting or forgetting to take diabetes medications can also negatively affect blood sugar management. When determining how diabetes may be affecting the worker, it's important to have an open and honest discussion about their medications and how well they are adhering to their physician's instructions. Stress, whether physical, mental, or emotional, which we experience all of those things in a typical workday, can raise your blood sugar. Lack of sleep will artificially elevate blood glucose. Fatigue, going hand in hand with the stress and the lack of sleep, can increase the stress hormone cortisol, which increases gluconeogenesis, which increases blood glucose levels. I threw in this slide here also the dawn phenomenon. If it's something that you haven't heard of, it's a very interesting and frustrating thing for a lot of diabetics. So as your body starts getting close to the time that it's used to waking up, your body will increase the glucose available in your bloodstream to fuel your brain and muscles. For someone that's not diabetic, it's not a big deal. That increase, your body puts it to use and it's ready there immediately. But for a diabetic that can't immediately, that doesn't have the insulin sensitivity to use it as it should be, it increases their blood sugar without anything for them to do about it, and it's pretty frustrating, especially since there's little they can do to prevent it and to keep it from happening. Exercise is a good thing, right? Well, yes, but that doesn't mean it won't raise blood glucose. So physical demand higher than normal can cause the liver to release more glucose into the bloodstream to fuel the greater demand on the muscles. So following the physically demanding activity, blood sugar should return to normal, but the worker may experience hypoglycemia, and accommodations might need to be made to bring the employee back to feeling normal. A cold or flu can be stressful for anyone, but it's amplified for diabetics. The immune response elevates blood sugar levels in response to the physical stress of the illness. Many OTC meds also have sugar to make them palatable, further increasing the diabetic's blood glucose levels. Same thing for injuries and surgeries. The stress of musculoskeletal injuries raises blood sugar, which can also make it take longer to heal from the injury or surgery. Dehydration will cause blood glucose elevation. It's important to drive home proper hydration for all workers, but even more so for diabetics. Providing adequate opportunities for hydration can help a lot. Tobacco use can elevate blood sugar in addition to all of the other health issues that it can cause. If you're caring for a diabetic worker who uses tobacco, I recommend referring them to their company's tobacco cessation program, assuming they have one available. And tying in with the hydration factor, if you care for employees who work outdoors or even just like to spend time outdoors outside of work, Sunscreen is another important tool to avoid blood sugar issues because a sunburn can cause elevated blood glucose. I've always been amazed with how the things that seem like mild inconvenience or discomfort for a non-diabetic can become a serious issue for the diabetic worker. As healthcare providers, the first and most effective recommendation for managing diabetes is lifestyle, particularly diet and exercise. Limiting carbohydrate intake, increasing fiber, protein, and water. Exercise, whether aerobic or anaerobic, helps the muscles use glucose in the blood and may improve insulin sensitivity and prevent diabetes in people with prediabetes. One of the best ways to manage blood glucose levels is light exercise, like walking right after a meal. The next thing to consider is medication. There are several medications used to treat type 2 diabetes. Most of these are inappropriate and dangerous for a type 1 diabetic, which is primarily treated with insulin. These should be monitored by the employee's primary care provider and the endocrinologist. And in most cases, the biggest concern for the industrial athletic trainer is the possibility of hypoglycemia, especially if the employee is on a new medicine or a new dose. In recent years, glucose monitoring has improved from the old fingerstick glucometer method, and many diabetics can check their blood glucose instantly from an app on their phone. If they experience symptoms that don't necessarily match what the app says their glucose is, it's a good idea to verify their levels via fingerstick glucometer. But the monitoring, tracking, and modification with near real-time data make living with diabetes much more manageable. Now, I say near real-time because there's about a 5 to 10 minute delay between blood glucose changes and registering on a CGM app because the sensor measures glucose within the interstitial space, not actually within the blood. That's why it's always good to verify with a finger stick if anything seems off. A hemoglobin A1C measures the average blood sugar attached to red blood cells over the previous 2 to 3 months, and it's recommended quarterly to monitor long-term blood glucose management. An A1C of 5.6 or lower is considered normal. 5.7 to 6.4 is pre-diabetic, and 6.5 and above is diabetic. Diabetics are encouraged to maintain an A1C below 7.0. An annual comprehensive metabolic panel is good to monitor any systemic changes that may occur either because of or alongside of diabetes. The CMP measures 14 substances in the blood, including blood glucose, liver enzymes, proteins, waste products, and electrolytes, which paint a picture of the general metabolic health. Diabetics should get annual eye exams, including a retinal exam, to stay ahead of any diabetic retinopathy. Likewise, diabetics should get regular foot exams from either their PCP or a podiatrist to assess any changes in sensation, circulation, or skin integrity. There's not a lot that we as industrial athletic trainers need to know about the Americans with Disabilities Act and how it applies to diabetic workers. That's mostly an HR situation, but it's helpful to understand a little bit about it to help advocate for the employees that we care for. So in 2008, the ADA Amendment Act, diabetes was a condition added to the act as one that employers must accommodate for. Because of the verbiage of the ADAAA, even if diabetes is well managed with diet and exercise or with or without meds, it's considered a disability. Even a history of gestational diabetes that resolved after childbirth is still considered a disability that the ADA says that employers have to accommodate for. Obviously, employers can't discriminate based on a disability, and they can't ask a candidate whether they have a disability that may require accommodation. The employee is not required to disclose that they have a disability that may require accommodation, even before accepting a job offer. If a diabetic employee requires any reasonable accommodations, the employer can ask for documentation from the employee's healthcare team, similar to accommodations for a musculoskeletal condition. Once it has been disclosed to the employer that an employee has diabetes, they can share that information, but only on a need-to-know basis. So that usually includes the employee's direct manager or supervisors, so they can work together to make reasonable accommodations. This usually also involves the safety team, so they're properly informed in the case of a medical emergency, and any health personnel, including athletic trainers, for helping prevent, monitor, and respond to any kind of diabetic emergency. Finally, the employee's condition can be disclosed to workers' comp or insurance for claim management. Much of what we do in the traditional setting is reactive, so assessing, treating, and managing conditions in our athletes. In the industrial setting, we have the unique opportunity to lean on the first domain of athletic training, prevention. We typically think about prevention as it applies to musculoskeletal conditions and ergonomic hazards, but we're often the only available healthcare provider available to the industrial athlete. Very similar to the traditional setting, we're the first line of care for the traditional athlete. All of the preventative education in the world won't overcome genetics, lifestyle, and the standard diet of the average worker, and all the other unknown factors that combine to help develop type 2 diabetes. For this reason, it's important to employ effective screening tools. You may even be able to coordinate with HR or for employee benefits and enlist the help of a local clinic to provide free or inexpensive simple labs like blood glucose, A1C, and cholesterol. A side note here, this is also something that you can talk about for your value add on site. It goes beyond just protecting musculoskeletal injuries or reducing recordability. You are positively affecting the overall health and well-being of the employees and potentially even saving lives. If you have employees on site that you know have diabetes, you can set yourself up as their ally, encouraging good decisions and helping to monitor changes in their blood glucose related to working conditions. Knowing how the employees are affected allows you to make suggestions to supervisors and management to accommodate the health needs of the employees. Prevention is where we would like to come in on every situation. When we focus on prevention in the workplace, this gives us the opportunity to connect with employees and educate them on health and wellness topics, including diabetes prevention, proper diet and exercise, and weight management, which are all important in preventing type 2 diabetes. For the non-diabetic, we often consider complex versus simple carbs. But for the diabetic, the number of carbohydrates is the most important. As a general rule, higher fiber content carbohydrates have less effect on blood sugar. Many commercially available products will even tout their net carb count, which is probably the most important part for diabetics, more so than non-diabetics. Here's how most people calculate net carbs. You take your total carbohydrates, you subtract dietary fiber, you subtract sugar alcohols, which are neither sugar nor alcohol, but include things like erythritol, xylitol, and maltitol, among others. And you subtract allulose, which is technically a type of sugar and it tastes like sugar, but your body doesn't process it as sugar and it doesn't spike your blood glucose. Of course, this is a general idea that works for most diabetics, but everyone reacts to ingredients differently. Just as we would recommend a regular exercise routine for a non-diabetic worker for general health and wellness, we recommend a regular routine for the diabetic worker for both general health and wellness, as well as blood glucose management. This is often going to be encouraging the employee to start where they're able to, eventually working up to 30 plus minutes a day, 5 or 6 days a week. But if a walk to the end of the street and back is where they start, that's great. Because type 2 diabetes can often have comorbidities like cardiovascular disease or hypertension, it's important to understand how those things can affect their diabetes and how their diabetes can affect those other conditions. So it's not uncommon to come across a diabetic that doesn't realize it yet. As I mentioned earlier, it's estimated that roughly 8 million of the 38 million diabetics in the US don't even know they have diabetes. They haven't had any serious health concerns. They don't regularly see their primary care, and they haven't undergone any screening. Maybe they haven't reached the diabetic threshold, but they're in the pre-diabetic classification. That's when providing a screening tool like the one I've linked here can be invaluable. Let's go through a couple examples, so long as the technology allows. Let me try this real quick. Let me pull this. All right. So first, let's go through this example. We have a 38-year-old white male with no family history of diabetes, but has a personal history of hypertension that's managed with medication. He's 6 foot tall and weighs 175. He played basketball in high school, but besides the physical labor of his warehouse job, he doesn't work out often, unless you count esports, which I don't. Let's see what that looks like in here. So, less than 40 years old, male, no family history of diabetes, history of hypertension, not physically active, white, he is 6 foot tall and weighs 175 pounds. Results. So just with this screening tool right here, this results in a low risk of diabetes. So let's look at another example. So in another example, we have a 52-year-old, there we go. We have a 52-year-old Hispanic woman with a family history of diabetes and hypertension. She had gestational diabetes while pregnant with her only child, but it resolved after childbirth, and she's never been diagnosed with hypertension. She's 5'3" and weighs 175. She takes a 10-minute walk after lunch every day and does an hour-long bike ride every evening, excuse me, so long as the weather isn't bad. Woman, yes. Family history, yes. And no blood pressure, yes. Physically active, Hispanic, 5'3". So we can just see right here that despite her healthy lifestyle, her genetics, her family history, and personal prior medical history increase her likelihood of developing type 2 diabetes to a high risk level. Of course, this doesn't mean that she has diabetes or ever will, but she should have a conversation with her PCP and should be screened annually to be sure. Switch this back. So if a worker's reporting chronic conditions that may be indicative of diabetes, we can offer to test their blood sugar as a courtesy, but they should be referred to their primary for further evaluation, regardless of the result that we find. Many employers offer yearly blood sugar, A1C, and cholesterol testing as a benefit for their employees, allowing them to recognize the signs of potential chronic conditions early. If your client doesn't offer this, you may be able to work with HR and safety to develop an annual safety health fair and collaborate with the local health department to provide this service to the employees at your site. In my time as part of the Southeastern Illinois Community Health Coalition, we worked with state and federal grants to set up free screenings through the area, including blood glucose testing, A1C, cholesterol screening, even got the kidney mobile to come. So just reaching out to the local health department may open many doors for prevention and screening. So on here, by a raise of hands, who here has trained to use a glucometer in your athletic training program? Can you hit that button there on the bottom of your screen? Just about everybody, looks like. Good. That's something that I've been talking about with directors of or program directors for athletic training programs in the MSAT, and just so far it's been a good results in hearing that they can do those things. I don't remember in my undergrad athletic training program whether or not we did that. I know since then I've done a lot of different training in a lot of different areas and used it, but I couldn't remember whether that was part of my athletic training program. So I'm glad to hear that that's something that's readily available for everyone and it's part of your competencies. So besides lifestyle recommendations and symptom monitoring, blood glucose testing may be the biggest area of impact an athletic trainer in the industrial setting can have on a diabetic worker. Because of insurance limitations and the perceived high cost of supplies, many diabetics neglect to regularly check their blood sugar, and they rely solely on symptoms and their annual labs to know how well they're managing. In many cases, they can do just fine, but every once in a while, this is a recipe for disaster. Through the day, type 1 diabetics will need to monitor their blood sugar, and they will adjust their insulin injections based on their current levels. For this reason, many type 1 diabetics elect to use a continuous glucose monitor, which can give them an instantaneous reading of their blood glucose levels without the need for repeated finger sticks. And if they have an insulin pump connected to their CGM, it can adjust and administer insulin based on what their current levels are. Type 2 diabetics, especially those with diabetes managed well with oral meds and lifestyle, can also monitor their blood glucose with a CGM, but they may opt to only use the traditional finger prick method once or twice a day. Through regular glucose testing, a diabetic can monitor how all the compounding factors affect them as an individual, and they can make better lifestyle decisions to manage their diabetes. It's also important to drive home that managing diabetes is a marathon, not a sprint. Sometimes you're going to be out of range and there's very little you can do about it, like when you're sick or injured or when life happens. Instead of beating yourself up for a spike here and there, it matters more to try to make overall healthy decisions and trend in the healthy direction, maintaining blood glucose levels within a healthy range. Because A1C is an average level of blood glucose over time, spikes and valleys may even out to something that looks normal. Many endocrinologists are now using time in range as an overall indicator of blood sugar health, showing what percentage of time the patient is within that desired range versus what percent of time they are above or below their ideal range. So here's some scenarios we want to talk about, and this is a way we'll have a little bit of interaction if you want to join in. What are some ways an employer can provide reasonable accommodation for workers with diabetes? Here's an example. A manufacturing facility requires employees to work an 8-hour shift with just a 1-hour break for lunch. An employee with type 1 diabetes needs to eat several times a day to keep her blood sugar levels from dropping too low. What kind of accommodations would be reasonable for the employer to provide to this employee? Justin, is that a raised hand for this?
That was from earlier. I don't think.
Oh, okay. It just didn't go down. I got you. You're allowed to talk if you guys want to. Right. Unless it were to cause undue hardship, that's the qualifying phrase that is used as far as accommodations go. The employee could accommodate the employer, could accommodate the employee by allowing her to take 2 15-minute breaks each day and letting her make up the time by coming to work 15 minutes earlier and staying 15 minutes later. So you're still getting the same amount of work, the same amount of production out of the employee, and making accommodations to maintain blood sugar levels in this type 1 diabetic. So here's another one. A custodian tells his supervisor that he was recently diagnosed with diabetes and needs a week off to attend a class on how to manage the condition. The company has a leave policy requiring 60 days prior notice before taking any personal time off. What would a reasonable accommodation be for this employee? So if a leave for this length of time and or for this reason wouldn't be allowed under an existing leave policy, the employee's request for leave is a request for reasonable accommodation, which in this case would be an exception to or modification of the leave policy. There are some simple, reasonable things an employer can do to accommodate diabetic employees. Some of them seem pretty obvious. Others might not have occurred to you before, but they make sense when you think about them. A private, clean area to test blood sugar or administer insulin injections. In many facilities that have an athletic trainer, the athletic training room or first aid room or whatever it's called for that particular facility is often that safe space. In facilities without on-site healthcare providers, that safe private space can be in or near HR or safety, which is convenient if safety is responsible for bloodborne pathogens and sharps containers. Speaking of sharps containers, it's also helpful from an environmental standpoint to have an appropriate sharps container for lancets and needles. This private clean area can also be helpful to allow the employee to rest while their blood glucose levels return to normal, following whatever intervention they require. Outside of the clean private areas for testing and treatment, other reasonable accommodations may involve time. For example, a flexible schedule to allow the employee to attend medical appointments, test their blood sugar, administer treatment, and rest if necessary. Allowing brief breaks to eat, drink, or take medication is helpful for diabetics to maintain steady blood glucose levels through the workday. Some other employer accommodations can also be viewed as a benefit for all employees. For instance, offering healthier food options in break rooms, vending machines, and cafeterias. Fresh fruits and vegetables, pre-made salads and dairy products like cheese, cottage cheese, and no sugar added yogurt are much better than the processed, pre-packaged foods typically available. If the facility has a cafeteria, providing lower carb, higher fiber hot options like steamed or sauteed vegetables, rice cauliflower as a rice alternative, and spaghetti squash or zucchini noodles as a pasta alternative can help maintain steady glucose levels and promote healthy choices, even in the non-diabetic workers. Even if these things are available at the facility, permission for diabetic workers to eat small stacks of their workstation may help maintain steady blood sugar levels through the shift, avoiding spikes and crashes. Whether your facility has the available space and budget for a fitness center or even a defined walking path around the work campus, encouraging movement and providing a safe area to move are a benefit to all the employees. This is especially helpful for the diabetic employees because physical exercise helps the muscles put the glucose to use and maintain steady blood glucose levels after a meal. Probably most familiar for athletic trainers in the industrial setting, ergonomic equipment can make a big difference for diabetic workers. Because diabetics are more likely to develop sensory issues like numbness and paresthesia, designing work implements with ergonomics in mind can help reduce some of the long-term complications of diabetes while improving productivity. Some examples that should come to mind are tools with ergonomically designed handles, anti-vibration gloves, and anti-fatigue mats. Because diabetics are also more likely to experience vision and hearing impairment, accommodating for light and noise within the work area will improve the overall work experience and limit long-term symptoms for diabetics that may affect their work. So wrapping things up, I want to drive a few points home. First, diabetes is much more than a simple dietary restriction, and management takes much more than decreased sugar intake. Diet, exercise, and often medications help treat the disease, but many contributing factors are uncontrollable. Roughly 1 out of every 5 diabetics does not realize they have diabetes and may be doing irreversible damage on their body while it remains unmanaged. For this reason, it's it's imperative for industrial ATs to recognize the signs and symptoms of diabetic complications. Develop rapport with the employees so they feel comfortable trusting you with more of their health information, and direct them to proper resources when you believe diabetes may be a factor contributing to their overall wellness. Athletic trainers are often the first or only healthcare provider a worker may see. This is our opportunity to live up to our Swiss Army knife reputation and positively affect lives by applying our skills for prevention and assessment, making the proper referral when diabetes may be part of the equation. To prevent long-term complications and help manage this chronic disease, It's going to be imperative to fight the stigma of diabetes and provide the best possible care without judgment. And finally, we can advocate for the diabetic worker while supporting our clients from a health, wellness, and even ergonomic standpoint by understanding the causes of complications, effects on work, and how we can partner with the employer to provide the best possible work environment for the diabetic worker. Industrial athletic trainers are uniquely positioned for this, and we should take advantage of this position. So here's some more resources to check out for additional information. Obviously, the American Diabetes Association, they focus solely on providing information on prevention, assessment, and treatment of diabetes. The Americans with Disabilities Act website can help develop accommodation strategies for diabetic workers. The Diabetes Research Institute Foundation has some great educational materials to share with diabetics, especially the newly diagnosed. Novo MedLink has a clinical education library with several informational handouts and brochures available in both English and Spanish. And finally, the National Institute of Diabetes and Digestive and Kidney Diseases, it's a mouthful, is a great source for more educational materials. Questions?
Chris, I got one for you.
Sure.
Given your experience, what are some of the most challenging aspects of diabetes in the workplace, particular with industrial versus athletics?
I think in the industrial versus traditional athletics is one. Traditional athletics, you're going to run more into type 1 diabetics, far fewer type 2, just because the condition that most of the traditional athletes are in. So it's a different idea of managing altogether on that side. But I think it's the combination of the stigma of diabetes in the first place, that feeling that they're to blame for their condition, but then also actually managing it, looking at it from an ergonomic standpoint, because diabetics are more likely to develop things like carpal tunnel syndrome, cubital tunnel syndrome, frozen shoulder. These are things that we need to look at in one, helping to prevent future health issues for the actual diabetic, but to design work around to prevent those conditions from happening. We're not going to prevent frozen shoulder in a diabetic. It's an interesting thing, the way that happens, and why that happens. And I don't know that we have a clear answer of why exactly. But things like carpal tunnel and cubital tunnel, other neurosensitive issues are things that we can help prevent. And looking at ergonomics as a way to do that and to advocate for the employee is an opportunity that we have.
Yeah, I was just I was typing while you were saying that too. Just with the same thing with like Charcot deformity. I had a midfoot, what looked like a potential like a Liz Frank or something there, ended up coming back as like a Charcot deformity, where that that midfoot was just kind of starting to deform because of the diabetes. So that's definitely interesting. Yeah.
Yeah, and I think that has to do with the way. The way that the soft tissue, the tendons are affected also by just diabetics or diabetes and the microvascular issues.
And I do want to open it up to everyone for questions, but I'm curious if there is anybody out there that has either a accommodation process that they're proud of with diabetes management, or if anyone's having struggles with helping workers get accommodations for diabetes management.
Hey, Chris and Michael, it's Callie from Peeper Electric. I wouldn't say we have issues like providing accommodations, but I guess how do you guys go about encouraging employees to share if they are a diabetic, just from that perspective? Like, I'm used to high school, college setting where it's a very well-known thing. Here it's a little bit quieter, and frankly, we have 1,500 employees. So I guess how do you encourage them speaking up about it and making sure we can keep eyes on them and then provide the accommodations they might need?
I think the first level of that is from an educational standpoint. One, I mean, I've hit it probably 4 different times, is just removing that stigma, taking that shame idea out of it, and encouraging them to be open with you about all of their conditions. Even if we're just understanding from an emergency medicine standpoint that something could happen and you need to understand that. Developing that rapport with them, obviously with 1,500 employees, it makes it more difficult to have a one-on-one professional relationship with everyone. But as you're able to, it's good to just really have an open conversation with them as often as possible, which still really springs from that educational side. If they feel like you understand their condition and what they're going through, and that you are an ally for them, you're not judging them for their condition. Really, that's probably the best way to go about it. You could have something where if HR understands or HR knows about it, they can automatically report those things to you, which is just a good policy to have in general. But really, you're going to get the most out of establishing those relationships.
Absolutely. Thank you.
Yeah, thank you.
Chris, looks like we got a question that says, what do we need to be aware of when someone with diabetes presents with MSK or musculoskeletal issues and we're under OSHA guidelines for interventions? Do we avoid taping completely? I assume that they're restricted where they can't do treatment beyond first aid. I believe that's what
Sure. Yeah. If we're sticking to a treatment within first aid protocol, I don't think that the diabetes diagnosis should make that big of a difference in most cases. We need to be aware that it's often going to take longer for the healing process, and that there may be some sensory issues, there may be some microvascular issues to take into consideration there. As far as taping goes, unless there is some kind of skin integrity issue, I wouldn't be concerned about that. There's some people that'll say because of the potential for skin integrity issues, maybe use, say, kinesiology tape for a shorter period of time. So let's say the average person keeps it on for 4 or 5 days. Maybe a diabetic does 2 or 3 days. But at the same time, understanding if you're using something with a very strong adhesive, removing that in 2 or 3 days may affect skin integrity. So it's really going to be on an individual basis. But I don't think knowledge of their diagnosis will really limit us in our scope of practice and what we can provide to them on a first aid basis.
Yeah.
This concludes the IATS OnDemand Continuing Education Program video. To claim your CEU, you must be a member of the Industrial Athletic Trainers Society and complete the From Claim Your CEU found in the YouTube description. If you have any interest in learning more about what the Education Committee has to offer, reach out to the email address on your screen. If you would like to volunteer your time to speak on a topic that interests you, please reach out. Thank you and stay safe.